Hi, good afternoon, and thank you for joining PQA for today's Quality Forum webinar. My name is Richard Schmitz. I am PQA's Senior Director of Communications and moderator for today's discussion on medication therapy management. Before we get started today, just a couple of housekeeping items on the webinar. Please submit your questions for our panelists using the questions feature located on the webinar control panel. At the end of the presentation, we'll cover as many questions as time permits up until the hour. This forum is being recorded. A copy of the slides and audio recording will be shared within a week, so be on the lookout for that. And then we welcome your feedback. There will be a brief survey at the end of the webinar. We're particularly interested in your ideas for webinars in 2019. So with that, we will get started. Our presenters for today are Kari, Trapskin, and Alan Lukazewski. Dr. Trapskin is Vice President of Healthcare Quality Initiatives for the Pharmacy Society of Wisconsin, and she has coordinated the Wisconsin Pharmacy Quality Collaborative Medication Therapy Management Program since 2006. She was a co-principal investigator of the Wpqc CMS Healthcare Innovations Award between 2012 and 2015. And Mr. Lukazewski is Director of Clinical Pharmacy for the WEA Trust. He has spent much of his career providing high-level services to older adults. He has also worked in long-term care and retail pharmacy, and he has been widely recognized for his work to reduce the risk of adverse drug events and falls in older adults. So with that, I will now turn things over to our presenters to get us started.
Great, thank you, Richard. This is Kari Trapskin, and like Richard said, I'm joined by Alan Lukazewski here, and we're going to tag team this presentation for you today. So we'll be talking about the Wisconsin Pharmacy Quality Collaborative and results of our collaboration with WEA Trust. So by the end of this presentation, I hope you'll be able to describe the history of the Wisconsin Pharmacy Quality Collaborative Program, discuss the targeted collaboration between WEA Trust and WPQC, and then list the outcomes of the WEA Trust WPQC hypertension pilot. So just a little bit about the Pharmacy Society of Wisconsin. We are the state professional association for pharmacists, pharmacy technicians, and pharmacy students in Wisconsin. We represent professionals in all practice settings. We represent those in hospital practice, community practice, academic, etc. Our mission is threefold: education, advocacy, and practice advancement. And we're located in Madison, Wisconsin. So I wanted to just provide a little bit about what we do in terms of education. So we hold annual education conferences, so about 5 of them, and provide continuing education credit for attendees. We publish a journal every 2 months, the Journal of the Pharmacy Society of Wisconsin. We provide weekly e-newsletters for our members, as well as the WPQC program, technicians, long-term care pharmacists, etc. And we also have been involved in coaching work groups to help people implement comprehensive medication reviews by facilitating conversation and best practice sharing. And this would be amongst the WPQC pharmacies in the process of implementing comprehensive medication reviews into their workflow. These are phone-based sessions following a standardized curriculum. In terms of some of our practice advancement work, WPQC has been part of that work for me for many years. We publish toolkits, so chronic disease toolkits. We have 12 of them, including one that focuses on medication adherence. We've worked extensively on collaborative practice agreement templates, and currently we're involved in some final product verification pilots, so where we're blending the work group coaching sessions that we do with WPQC, as well as blending that with tech programs or final product verification pilots to overcome the barrier of people implementing comprehensive medication reviews in their pharmacy. So just an example here of the clinical toolkits that we provide actually to all of our WPQC pharmacies, as well as members and others who are interested in them. They follow the standard CMS chronic conditions. So let's transition back into the Wisconsin Pharmacy Quality Collaborative. We began working together with our first payer in 2008, which makes 2018 our 10-year celebration of this program. We developed the program collaboratively from the ground up with pharmacists and payers at the table. In 2012, the state Medicaid program joined us, and that was about the time when we were awarded the CMS Innovations Award that we ran through 2015. So a little bit on the fundamentals of WPQC. We're basically a network of pharmacies with certified pharmacists providing medication therapy management services, mostly comprehensive medication reviews to patients. We accredit WPQC pharmacies based on a set of 7 quality-based best practices. Those best practices include things like pediatric dose checking, continuous quality improvement programs, and really making sure that the pharmacies have a policy and procedure in place for all of these things so that they are implementing them on a consistent basis within their pharmacy. We also certify the pharmacists who are part of the accredited pharmacies. So central to the program is really that fundamental idea that pharmacists have a specialized skill set and expertise that when used in a team care partnered with physicians and other members of the healthcare team, that we can complement and supplement the team-based care focus and approach. So today we'll focus most of our discussion here on the Comprehensive Medication Review and Assessment Services, or the CMRA Level 2 services. On this slide, you'll see the eligibility criteria for the Level 2 services. So patients who are eligible for these services through the Medicaid program here in Wisconsin will be taking 4 or more prescription medications to treat or prevent 2 or more chronic conditions. These include hypertension, asthma, diabetes, chronic kidney disease, heart failure, dyslipidemia, COPD, or depression. They can also have simply diabetes to be eligible for the Comprehensive Medication Review. They can be receiving prescriptions and care from multiple providers, be discharged from the hospital or long-term care setting within the past 14 days, and that's a single criterion itself, have low health literacy, or simply be referred by a physician. So the initial comprehensive medication review service that's covered through this program involves a 45 to 60-minute sit-down encounter. It's required to be face-to-face for this program. It really follows the standard MTM definition that many groups have been working off of for many years, and thus follows that it's the identification, resolution, and prevention of medication-related problems. And then the communication is required to providers and patients, including the clinical documentation or summary of the visit, the personal medication list, and the medication action plan. So we also have built into the program 3 follow-up visits every year. And unique, I think, to this program is that patients can also receive a comprehensive medication review after each discharge from the hospital or long-term care facility. So we call it a transition of care service with a medication reconciliation component. Obviously, this helps to deal with the complexity of transitioning patients and their care via the medication reconciliation and really the care coordination that really crops up when patients are going back to see their home community pharmacy. These are not expected to follow the typical initial and follow-up visit structure. They're really one-time initial comprehensive medication reviews, and obviously, hopefully intended to decrease the readmission rate for members of Medicaid. So this slide shows a map of our participating providers in 2018. This is the map of Wisconsin. The purple counties are the counties that we have at least one pharmacy located within it. We have 230 accredited pharmacies across the state currently, and 534 certified pharmacists as well. Technicians can also get certified for this program, and we've definitely shown that technicians who are certified are typically located at the pharmacies that are higher utilizers and who have been more involved in the program. We have more or less a pretty even split between chain, health system, and independent pharmacies involved in the network. You see that up on the top right of the slide. So our independents have a few more than the other types of pharmacies, but we do have a fair mix of all three types of pharmacies. Currently, we have the Wisconsin Medicaid program involved in our as a participating payer, as well as the United Way of Dane County, which is more of a local arrangement where we focus on adverse drug events and falls. And then we, as we'll discuss in a few minutes, we've entered into some work here with WEA Trust, which is really exciting. So currently, we have, since the beginning of the program, performed 9,070 level 2 or those comprehensive medication review services. We have a goal of getting to 10,000 by the end of March, which would coincide with the end of our 10th anniversary year. So we've been really fortunate that we've sustained this program over the 10 years plus that we've been working. It's obviously had different challenges and it's looked different over time. But specifically to the Wisconsin Forward Health or the Wisconsin Medicaid program, they did a review of our program between 2012 and 2015 and showed a decline in inpatient costs for patients that received those comprehensive medication reviews in comparison with inpatients who didn't receive. So there was a control group and an intervention group, and those patients, they were all admitted to the hospital, and those patients who received in the intervention group, who received the comprehensive medication review, had lower acuity and lower costs for that stay. And so we think that that's potentially suggestive of decreased costs for this group of folks who have received comprehensive medication reviews. We see potential for change in the future as value-based payment becomes more common, although this program currently is based on a fee-for-service model. So let's transition a bit to talk about the Wisconsin Division of Public Health and a specific pilot that the Wpqc pharmacies have been participating in with WEA Insurance. So for the last 5 years, we've been really fortunate as the Pharmacy Society of Wisconsin to be involved with the Division of Public Health here in Wisconsin. We have been working with them on their cooperative CDC funding through the Chronic Disease Prevention Program. So that work has allowed us to focus our efforts on adherence, self-measurement of blood pressure, promotion of medication therapy management, the Wpqc program specifically, and developing and sustaining health plan connections. So since mid-2018, the Division of Public Health, we work really closely with, secured funding through the Association of State and Territorial Health Officials, or ASTO. So they brought this opportunity to us to work on a hypertension-specific pilot with WEA, given some work that, or some conversations that have been happening. They have provided technical assistance and epidemiology support, which has been a great partnership as we've worked with WEA and the Wpqc pharmacies. For the second round of this, we received some funds to help with the process through the Division of Public Health, and our focus has been hypertension. So WEA Trust is a not-for-profit health insurer in the state of Wisconsin, developed by teachers for teachers in 1972. The trust serves over 100,000 lives of public school districts, municipalities, state employees, and retirees. So Alan's going to be talking more in a few slides about the results of this work. But for now, I'm going to talk a little bit more about the hypertension intervention and what we've done in the last 6 to 8 months. So the purpose of our working together with WEA and the Division of Public Health was really to provide a program that targeted hypertension-specific comprehensive medication reviews. So specifically, our purpose was to demonstrate improved hypertension outcomes through this collaborative partnership between the Department of Health Service, or the Division of Public Health, WEA Trust, and PSW. Our desired outcomes included improving hypertension-specific patient knowledge, increasing the frequency of self-measurement of blood pressure by patients in the evaluation, frequency of use of blood pressure and medication logs, as well as a reduction in adherence barriers. And with this, health beliefs that were built into our survey tool. So what did the patient selection look like? We were really fortunate to be able to work with WEA Trust and their data analytics team. We were able to look at those patients with, we'll look at their proportion of days covered to antihypertensive medications. So we found the patients that had a diagnosis of hypertension and then looked at their proportion of days covered, layered on top of that those who used a Wpqc pharmacy for their medications, and then what county they were in. And we were also looking at de-identified individual member data. And that allowed us to select pharmacies that we were going to outreach to participate in the program. And that was part of my role, was to outreach to the pharmacies. And because we had a good relationship with them, because they're part of our network already, we were fairly successful at getting pharmacies to participate on a really quick timeline. So we ended up working with pharmacies located in the Kenosha area, Baraboo area, Reedsburg area, and Antigo. So as I mentioned, that was part of my role to reach out to these folks. They're all WPQC certified pharmacies, and we ended up working with them during 2 different pilots. We're on a really quick timeline in terms of this work, just given the ability to use the funds from ASTO as well as the Division of Public Health. So you'll see that the pharmacists really came through, and it was a great collaboration between everybody. So these are the pharmacies that we worked with, the 4 in Kenosha County, 3 in Sauk, and then 1 in Langlade. So in total, there were 8 pharmacies that we worked with. The first pilot round was six of these pharmacies, and the second was 2. So the project really involved these pharmacies providing 2 hypertension-specific comprehensive medication review visits in person to patients that were on this targeted list provided by WEA Trust. So the patients were to receive a free blood pressure monitor as an incentive, as well as a $25 gift card to a local gas station. The pharmacists, in terms of an incentive, received somewhat of a hybrid payment. So they received a fee-for-service payment for each visit, as well as a fee for marketing as well as data collection. So we wanted to split those out so that it wasn't all bundled together with the actual service payment. The pharmacies received patient handouts to provide to the members that partook in the services. They received self-measurement of blood pressure handouts as well as adherence handouts. We were really attempting with this work to align incentives for participation so that the patients were incentivized to participate, the pharmacists were incentivized to participate, and of course, WEA was incentivized to participate with the outcome. So what did the outreach look like? I think let's step back for a minute. I think unique to this pilot was that we really tried to coordinate the outreach and the marketing. That was what we really wanted to do to make a change as we implemented this small pilot program. So we used a multifaceted marketing approach. WEA and pharmacists outreach to patients, and again, provided those incentives that hopefully brought patients in and brought the pharmacies excitement about being in the pilot. So WEA sent out a targeted letter initially to the patients that were on the analysis. And then pharmacies, within a week after the patients should have received the letter, were asked then to provide a phone call or an ask when the patient was in the pharmacy to participate in coming in for 2 visits. So the WEA as well was in communication with us at the Pharmacy Society as well as the Division of Public Health. They were reaching back and forth out to the pharmacists as well as us. And then we had a survey that was coordinated by WEA that was intended for the pharmacists to provide during the comprehensive medication review, and it really kind of walked them through the process, but also got documented the pieces of data that we were looking for. So as I mentioned earlier, the pharmacists were part of the WPQC program. They were already certified, so they had already completed our standard WPQC home study training. For this specific pilot, we provided them additional home study training videos on adherence to blood pressure medication, as well as home study on self-measurement of blood pressure and blood pressure technique videos, because we were going to be requiring them to be taking blood pressure as well as identifying barriers and solutions to adherence. So we provided these tools as well as one webinar on the process prior to the launch. As certified pharmacists, they are provided those toolkits, the chronic disease toolkits that I was speaking of earlier. And this is an example of one that was pertinent to this pilot. So they were provided the Hypertension Toolkit. This was newly updated with the new 2017 ACC-AHA guidelines, but it also includes the 2014 JNC-8 guidelines to make sure that we were covering all of our bases. Additionally, pharmacists had access through WPQC and PSW to our Adherence Toolkit. So this toolkit basically breaks down adherence into different domains based on social determinants of health. So it breaks down the barriers to providing, barriers to patients having good adherence into different domains, and then provides specific solutions to those specific barriers. We also have supplemental resources on our website. Those are actually public domain, so anybody can have access to those. There's a link here for some of the resources as well if you want to access those. So one of the pieces, kind of the backbone of the Adherence Toolkit, is barriers and solutions, and we break them down into 5 different domains. We like to call this our SMURF mnemonic, so system, motivation, understanding, recall, and financial, because we really don't want people to just be looking at throwing a pill box or a med box at every person that has seemingly low adherence. So we want them to think about, what are the things that are actually the root cause of people's adherence. What it does is it provides targeted motivational interviewing coaching strategies and phrasing to address barriers that are identified in each domain. So hopefully I've given you a picture of the training and the backbone of this program. I'd like to turn it over now to Alan to talk about the results that we've seen from the 2 pilots.
Thank you, Kari, and good day, everyone. This is Alan Lukazewski, and looking at the data in the table, basically you can see that we identified 145 members, and each of those 145 received a letter, at the very least from us. And then, as Kari mentioned in the process in prior slides, they received a call from basically someone from the pharmacy. Interesting to note, just so you can learn from this all, is that only one member called back to the pharmacy in response to the letter. It was really the pharmacist outreach or the pharmacy technician to be able to get patients enrolled. So what's important is to understand how we actually drive participation or engagement. I think the joint marketing with the letter, kind of setting the stage as to the program, the incentives that are offered by it. But then, of course, the relationship with the pharmacist and the pharmacy technician, which I would basically put as rapport, was probably helping with regards to the engagement of the program, kind of like that 2-pronged approach to be able to get engagement. So of that 145 population, we ended up with 61 members participating for 42% overall over the 2 pilots. And moving to the first visit, as you recall, there were two visits, one basically with the survey completion and the blood pressure check, the consultation with the pharmacist, and that exact visit repeated. So at the first visit, we had a completion rate of 100%, 61, and then at the second visit, 59%. And I would just note that I do believe, and Kari can correct me if I'm wrong, but we only had 59 because the pilot had a deadline to it, and we could not actually take data beyond that point. But most likely we would have achieved 100% completion rate over the course of the two visits or the pilots. So as a payer, although a provider for 30 years and moving into the insurance industry, understanding my role as a healthcare provider, providing motivational interviewing, health education, engaging patients is paramount, and kind of reflecting to the previous slide, again, having rapport with your clients, your customers really helps with that. But in the insurance industry, what we've struggled with, and I think it's pretty much universal, is what we call an engagement rate. And that would be somewhere where you do outreach, whether it be some sort of telephonic or by letter or combination, offering various programs and incentives. But typically what you see in a lot of different population health programs is maybe 10, 12, 15% engagement at the most. So what's very encouraging and noteworthy is the very high engagement rate that we had within this program. That to me is important because we can design the most effective program. If we can't get the people that we target, that we want in the program to participate, we're just not on a population health basis going to move the numbers and improve the health of the population. So that is, to me, a very profound finding from this pilot. And we did 2 pilots, and we're going to expand this into next year, and hopefully we continue to see these high engagement rates. So in the first cohort, the first phase basically was a 59%. It was lower in the second one, but we ended up with an overall participation or engagement rate of 42%. So again, to review, I think the incentives make a difference. I mean, we're basically allowing people to get a free blood pressure kit and a $25 gift card to Quick Trip gas stations and throughout Wisconsin, and maybe that was an incentive enough. The ease of use, they're going to these pharmacies to begin with, so it's almost an established or guaranteed site visit. So I think aligning the incentives, the rapport, and basically the ease of use allowed us to partner with DHS and PSW and our pharmacies, our network pharmacies, to be able to be very specific in our targeted interventions. So just some more data. The time between visits were ranging anywhere from, I believe, 6 to 33 days with an average, and I'm not certain it's median exactly, but it's pretty close, of about 15 days. So I would guess that the visit that went at 6 days, perhaps that person was more motivated to get their gift card, but it went as long as 33 days. And one might question, do you actually get persistent, sustainable results from any program with 2 visits so short between each other? And the answer is, for the most part, yes. If the program is properly designed, you can reference the Stanford University Chronic Disease Self-Management Program, where they basically, in less than 6 weeks, you can actually measure program effects of changed behavior, changed health beliefs, and long-term effects of basically improved ability to manage chronic conditions. So actually, these data are measurable, but again, a little on the shorter end. We'll try to find out next year as we extend these pilots and maybe a longer tail to them, how we can see persistence in engagement with our members. So to get the data, each pharmacy was given an iPad with access to the survey to complete with the patient before each visit. We managed the data for HIPAA purposes to be able to come back into the trust and basically de-identify and aggregate the data. The survey content would have been basically checking blood pressure. The pharmacist would do that, and heart rate. All pharmacies did at least 1 blood pressure check, and just a cursory review of that data just yesterday got the impression of about 50% of the time they did a second blood pressure check, and maybe in some individuals there was a third. And then, of course, when they were getting more than 1 blood pressure check, they averaged that to be able to get what was perhaps a closer to reality reading on that, as we are trained to do. They would also, in the survey, basically find out if, did the people understand what are their goals? In other words, based on, as what Kari was saying in the hypertension guidelines, do they understand what an appropriate target is for them, whether or not they have diabetes or other conditions? What is an appropriate blood pressure target, of which many people did not fully appreciate that. Excuse me. Adherence barriers was important. We need to understand, and Kari elucidated that earlier in terms of the reasons for non-adherence and understanding that and basically helping people get beyond those barriers. And we'll see some more data on that in a moment. And basically, lastly in the survey would be methods for monitoring health and lifestyle, more specifically, use of a blood pressure monitor and a log of blood pressures, tracking, monitoring the data. And of course, did they then basically use a medication log? And we can use log in a very broad sense. Was it something that was maybe the log on the blood pressure machine itself, or is it a phone app that people use and so forth? I use one myself. So they could use various methods to be able to log blood pressure or that of their medication adherence. I think one thing I want to point out at this point, since they measured blood pressure, the program design could not necessarily measure the effects of pharmacist intervention on blood pressure. It's too short, and it's not also measuring all the other clinical interventions that you might see with a provider system involved. And it's very important to understand that when designing a study like this. But one thing that basically was notable, because some pharmacists were doing those blood pressure measurements 2 and 3 times on a visit, was the variation in blood pressure. And that intrigued us, and I talked with one of the pharmacists in the program, talked to Kari and DHS about that. And timely enough, just a few months ago, a study from the European Heart Journal referenced their study to show that significant variation in either systolic or diastolic blood pressure may be a marker, a valid marker of impending cardiovascular events or higher risk. So we'll see what that lends towards next year in our sensitivity to that and more longitudinal work to be able to perhaps use that as a marker to address with physicians and patients perhaps more assertive management of their hypertension. So further, we can then look at the health questionnaire. Do you use any of the following to help you manage your BP? So at the first visit, which is any pre-intervention or interaction with the pharmacist, 14, basically out of the 61 or 24% were checking their blood pressure at home. After the second visit, that went up to 53. Well, 89%, and why wasn't it 100%? We gave them a free monitor. But anyway, we'll get there. It was only 2 visits. Then, of course, we saw similar data in terms of logging blood pressure, of basically 14 or 24%, and that increased substantially also. Again, a short-term timeline, but again, durability of these data, we'll find out if we can persist to 6 months to a year, which will be quite relevant. Then, of course, a log to track medication. 7% actually did, and I found that interesting. But at the end of the second visit, we found that 24% were actually tracking their blood pressure medications, which that is a very interesting finding. So here we have the visualization of from site visit 1 to the second visit, the shift in their rating of what were the values or their perceptions of barriers to adherence. Of course, a 10 would have been a number of people that noted that that was a problem. You can see the shift downward in all of these, except payment or cost of medication, and that probably has to do with drug class. As we all know now, in terms of managing hypertension, everything is available generically, and many insurance companies incent with 0 or low copay, so that was not the issue. And that actually is important to understand. We tend to actually attach perhaps societal perceptions or what we see on a high level as barriers to adherence. We always hear about cost. That's not always the case. For example, in rheumatoid arthritis, side effects and health beliefs as to the benefit of the med are more drivers as to whether or not people would adhere to their medications. And what you can see in this visualization is that it appears that pharmacists were actually moving the dial on getting people to basically better understand how to take their medications, perhaps eliminating or modifying some barriers, getting them to understand that maybe side effects were not as much a concern, and that actually is quite measurable and valuable in terms of what we might see down the road in terms of improving adherence and health outcomes. And 98% agreed or strongly agreed that as a result of their visits, they're going to take a more active role in managing their blood pressure. Well, we would hope so. That was quite an effort that we put forth. Nearly 100% rated their pharmacist care as very good. So you can read across here in terms of explaining suggested changes to medications, how to understand how to take medications, and that might have been reflected in the change of how members felt about adhering to their medications from this first visit to the second visit. Understanding the purpose of the medication, that gets to health beliefs, and then people, when they really appreciate the value of taking a medication, are more likely to adhere to it. Also, the effects of high blood pressure, which actually quite profoundly in people with diabetes, for example, managing blood pressure in a certain subset might be more important than managing blood glucose. So we cannot underscore too much the importance of managing high blood pressure. And also answering any other questions they may have had about their medication. So patient testimonials. One had stated he's glad he found out about my cough side effect. Gee, I wonder if that was an ACE inhibitor of my current medication. They will call my doctor to discuss. And I want to use that as a point to make that we have a model or philosophy at the Trust, and it's important to follow the model of the 3 Ps. That is, the patient, the provider, and the payer need to all work together in order to get to best outcomes. In this case, the pharmacist acted as a surrogate to the provider, or actually a provider, but then would intervene with the physician to get an appropriate medication change to something that may not produce that cough or side effect, whereby which the patient may not end up adhering to their medication. And I would reflect back to another hypertension survey that we did, where about 23% of the people were non-adherent. Of course, that was based on PDC value. As you know, PQA is very use-oriented to PDC, but actually only one had admitted that they were non-adherent. But a lot of the reason why people were not taking medications was ACE inhibitors causing cough, and a lot of people had that as a primary reason from changing to an ACE to an ARB. But I want to point out the value of this program. We talked about engagement. We talked about proper design and how we shifted some health beliefs and perhaps barriers to adherence. But that model of the 3 Ps, using pharmacists as providers with the patient and the payer, may help us in a targeted manner to get to deeper, more meaningful outcomes.
Okay, I'm going to transition back to me talking about the Pharmacist Survey. So we also did a satisfaction and barriers survey following each one of the pilots. It focused on the impetus to participate. We wanted to know, what really drove the pharmacies to say, yes, we'll participate in this very short time frame pilot, and really hands-on pilot, because it wasn't a simple thing for them to do. So we looked at that, who provided the different duties that were required to implement this program over a short period of time, what were the barriers, and then how much time was spent on marketing, visit, prep, and follow-up. So in general, the impetus for pharmacists participating was fairly equal between their desire to improve patient care, to increase adherence to hypertension medications, and then the coordinated co-marketing also factored in there, as well as the defined time frame. The monetary incentives was listed, but it was last in the sequence of things that were important. But we know that that's still a motivator for pharmacists, and we know that that's important and needs to be considered with any of these types of programs, because if we don't have the ability to offset and provide other ways to provide higher level services, that's just not able to happen within the pharmacy workflow. The training people thought was sufficient. They had no barriers in terms of knowledge, and I guess some of the things they thought could have been better was if some of the patients would be more willing to participate. So we had a really good engagement rate, but of course some of the pharmacists had some patients who just didn't want to participate. But I think overall we had a fantastic participation rate for this short time frame, and only like 1 or 2 times that the pharmacists were able to reach out to the patient. Some comments included the length of the pilot time could have been longer, which was a barrier for all of us. The patients did show up, though. That's something that we hear with a lot of our work is, well, I made these appointments, but the patients didn't show up. So how frustrating is that? I had extra staff and they didn't show up. So that was, wasted time and resources for the pharmacy. And then the physician response rate was very good, and that was also a motivator for the pharmacies. Things that the pharmacists enjoyed were the personalized interaction with patients, the face-to-face nature of these visits, and really just the ability to spend time discussing goals and concerns. A couple of other additional things that they said could have been improved were providing more patients to see. So it was an unequal distribution of patients that were provided to the pharmacies, and that wasn't by design. It just happened to be how it was with where people use which pharmacies people utilize. They liked the insurance, the collaboration between the insurance and the Division of Public Health and PSW. And actually, there were a couple of comments that they would have enjoyed more insurance company communication. And then, of course, that longer time frame for this. So we're hoping to make changes to that in 2019. One thing I should say that the pharmacists really appreciated and we appreciated, and this has changed over time, is that the first round, the ASCO funding actually paid the pharmacies. The second round, Division of Public Health continued to support the program and support pieces of it, but WEA insurance actually paid for the services to the pharmacies. And then in 2019, we'll be moving that into the full compilation of services being covered by WEA. So that's something that we've been working toward, and we're really excited about that partnership. Anecdotally, I've received favorable emails and additional interest from the pharmacies that have participated. They've been really excited about the work that they did and said, hey, and this is probably the majority of folks who have participated, hey, how can I participate in this in the future? Let me know. I really felt good about this participation. So all in all, the survey was very useful to us, and we'll use that to improve the program for the next go around. So right now we have a video, and I hope that this shows well for you. It's about 1.5 minutes. This depicts a pharmacist who was part of our pilot and one of her patients discussing their work with the hypertension visit that this patient, or visits, the 2 visits that this patient received. The pharmacist talks about her focus on multi-morbidity, so not just hypertension, as well as just really the broader discussion of how she enjoyed providing these services. And then I think what's noteworthy is that the patient really didn't have the knowledge that pharmacists were able to even contact her doctor and get things straightened out with some of her medications. So hopefully it'll come across. If the video stops, please try to listen to the actual audio because it is a great testimonial of some of the work that went on.
So after we met and really discussed what the goal of this program was, to make sure that they understood how to take their blood pressure and what that meant. And for some patients, we really took it a step further. If they had diabetes, let's tie that into your blood sugar. We're taking your blood pressure. Let's take your blood sugar. You're supposed to be doing it anyways. And it's a lot easier to change some activities in your day, your diet and exercise, if you're seeing that what you're doing is making a difference. I thought it was really in-depth, really nice. She had a lot of great suggestions for me. I went home the first time with a list of goals for myself with a beautiful blood pressure machine. I was floored when she said, I'll contact your doctor and we'll look at her, see if how she feels about increasing this medication. I've never, other than calling a prescription in or whatever, I've never known that pharmacists necessarily can communicate with your doctor. So the response was incredible. I think even the patients who understood what their blood pressure should be and already led a healthy lifestyle, they loved the idea of not guessing that it's good and actually taking it every day and seeing that it's good. It does really make a difference to have them here in person. Surely to give them the blood pressure meter and first of all make sure they know how to use it. And I would definitely recommend other people do it. I was pleasantly surprised. I basically came in and thought I was going to be here 20 minutes and she was going to look at my meds and say, okay, everything's good. It was far more elegant.
All right, I think we're back. Just make sure that I've got control of this. There we go.
There
okay.
we go.
All right,
Okay.
I think we're back. So hopefully the quality of that video came across for some of you. I'm sure it didn't come across for everybody. It was a really nice thing to hear the patients who were not scripted. These were not scripted videos at all, but just to hear the experience about their not understanding that pharmacists could even help them in this manner. And I think what we've seen the most is that patients really, really appreciate the time that's spent with them. So before I move on to previous WPQC experience, we wanted to just make one additional point about what we had seen with adherence. So I'm going to turn it back to Alan for a second here.
Thank you, Kari. I had forgot to make a note about something that we've found in the pilots in each of the pharmacies that's quite important for everyone to know. And that is that, as you know, we look at PDC, we're looking at data, we can stratify and so forth. And the idea is that we want to improve adherence in those that are, with a PDC that's inadequate. We use less than 80%, but why wouldn't it be 90 to 100%? But anyway, what we found, which actually is validated, it brought back a recollection of an AMCP presentation by a independent chain of pharmacies in Minnesota that discovered that just because somebody's adherent to their antihypertensive med does not mean they're actually treating to target. So I think that's important for anyone that is doing this kind of work. Is to the blood pressure is what matters most. Let's not necessarily not include people into these programs just because they're adherent. It's really what the blood pressure goal is, and are we achieving it? Back to you, Kari.
Great, thanks, Alan. All right, so in closing the next few slides, just want to give you a little bit of a sense of our previous experience with WPQC, how this differs, and then what our next steps will be. So our previous experience, we've been running this program in different capacities for many years now. We have the Medicaid program as well as we've worked with other payers over time, especially during the CMMI award that we had received between 2012 and 2015. We were really focused and still are focused on the large geographic area that the state Medicaid program covers. Between 2012 and 2015, we had implementation specialists who were located throughout the state, and they were able to really follow up, encourage, and focus on their specific area of the state to help people implement and really meaningfully make sense of this program. Interventions were pushed via a platform. We still have that ability, not in the same exact way, but we still have that ability through the Medicaid platform. And then we also had program information in the past was provided in maybe payer member newsletters, but not a lot of coordinated efforts to provide information to patients with a newsletter and then the pharmacist following up right after that. So that was something that we really tried to improve upon this go around. And then the short timeline was a limitation for this work, but it also, I think, provided us a nice timeline for people to really focus their efforts, for the pharmacies to focus their efforts over, an 6 to 8 week time frame Was it easy? No. Was it to the extent that we would like to see it? No, we'd like to have it be a longer time frame, but it did allow focused work. So that's kind of our previous experience. The limitations, additional limitations that we've seen, we had small member cohorts, but that actually probably made it a little bit more doable. Interestingly, in the second round of this work, we were implementing this in the fall, this past fall of 2018, and given that WEA covers a large majority of educators, we didn't have a choice, but we hadn't really considered that this was the beginning of the school year. And so a lot of the pharmacists said that patients actually declined. The people that did decline said, this is just a really bad time of the year for me to throw on one more thing in my life. So that was kind of something that I think going forward, we probably wouldn't design a new program for the fall of the school year. And then, as Alan mentioned, this really wasn't designed to follow adherence and blood pressure over time, though we did have that as part of our data collection. So we can't really conclude anything about those pieces. So I think in conclusion, we've been really pleased that this targeted collaborative approach has really shown success in a small population. Patient engagement has been higher than typical for this specific health plan. Pharmacists really appreciated the pilots and are eager to participate in additional targeted work. And I know we've got other pharmacies across the state who have heard about this work who are also interested. And then again, our sample size is really too small to draw conclusions on blood pressure changes, but hopefully going forward, we'll be able to get more into that detail. So future directions, as we've alluded to, we plan a comorbidity pilot in 2019 that we'll be working on together, really applying a similar model, although there will probably be tweaks based on our learnings. And then many of you may be familiar with the Community Pharmacy Enhanced Services Network, the CPESN, and we are, all of our WPQC pharmacies, all of the CPSN pharmacies in the network so far are WPQC. That's a requirement for pharmacies to be in the CPSN. So that's a really nice group of high-performing pharmacies that hopefully will also be able to help with this work going forward if they have the right payer mix of patients. So in closing, I'd like to offer special thanks to all of the participating pharmacies. They did a fantastic job. And then two DPH4 last year pharmacy students, Billy and Richard, who did a fantastic job keeping a lot of the communications going. Lena and Rebecca from the Division of Public Health, and then Jeff Carter and Elizabeth Solomon from WEA Trust, who did the analysis and a lot of the communication. And then Dr. Tim Bartholow from WEA with his support of this program. Acknowledgements go to both ASTA as well as CDC, who allowed the collaborative funding between us and the Department of Health Services. And with that, we would love to take any questions in the time remaining.
All right, well, great. Thank you, Kari and Alan. This has been a great presentation, and we really appreciate you sharing the results of the demonstration projects with us. So we have a little bit of time for questions. So the first question we received was about the home study training videos provided to the participating pharmacist. How long were those videos?
Yeah, great question. So the 3 adherence videos were a half an hour each, and they go through the workflow of our adherence model that the workflow that we've developed. And then the self-measurement of blood pressure videos were about 35 minutes each. There's 2 of them, one on teaching patients how to self-measure their blood pressure, and then one on how to, like the correct technique to take blood pressure yourself.
Great. And can you talk a little bit more about the incentives that were given to the study groups?
Yeah,
I can comment to
that.
Yeah,
okay.
We were not being specific mentioning the incentives. We wouldn't want to necessarily say that here's like a new benchmark or those things are negotiated based on value between any payer and the network of pharmacies. Plus, I can't say with assuredness without checking with pharmacies would they appreciate my necessarily revealing what the incentives were. But we did pay a substantial amount for them to do the outreach, and that was like a one-time fee for the pilot. And then for each visit, they were paid substantially. It just wasn't a one-time fee with follow-up. And I'll just say this, based on my involvement in negotiating community-based comprehensive medication reviews, where we would jokingly say, I'll spend $150 to get $75 of reimbursement. Basically, we basically made it worth their while where there's margin in there. And the whole idea that I'd like to see is, and I'm sure many pharmacists that are motivated, is to get into where value-based care can be delivered by pharmacies and adequately reimbursed and help supplement a new business model. We have problems with our healthcare or sick care system. It's all transaction-based and not necessarily very good at providing population health. I think in collaboration with payers and pharmacies, pharmacy chains, whether it be independents or larger chains, we can actually get into a different system. And if we can show that we can improve on outcomes and lower healthcare costs, we have a different reimbursement system. But again, so to reiterate, it was more than worth their time put into it, and it was very encouraging, and it was a shift from what I've experienced in prior programs. Accurate, Kari?
Yeah, yep, that sounds
Okay.
good. I mean, we're really focused at with this program in providing adequate reimbursement. When you only have one or two members or patients to see, it's a challenge no matter what. We do have payment through the Medicaid program for the state as well, and all of these payments might not seem adequate if you're only providing them on a onesie-twosie basis, but as you become more efficient and have more of a patient population, and this is part of your workflow, then it becomes more palatable. But yes, we definitely paid more for these services to make it worth their while.
Hope that answers the question sufficiently.
Sorry, we can't be more specific.
Yeah, you've got our contact info too, and you'll see further project work hopefully on that.
All right.
All right, Richard, any others?
Yeah, no, thanks. I think that's a great response to that. Regarding the participating patients, they received gift cards for participating in this. Is that right?
That is correct. It was a $25 quick trip gift card after the end of the second visit.
And then they also got the blood pressure monitor.
That's right, on the first one. Yeah.
During the visit.
Okay. So, Alan, one of the things that you kind of mentioned in the presentation, you talked about the profound finding for you about, this effect that the, engagement driven by the pharmacists and the technicians had in terms of getting patients enrolled and involved and participating in the study. Beyond expanding this pilot, just as a payer, how might you leverage, these types of interactions to, focus on other care initiatives or goals that you have for your population?
That's what we are now moving towards into next year. We talk about diabetes, but let's talk about multimorbidity centered around diabetes, this disease of lifestyle in America that's gone rampant, and it's associated with so much higher healthcare spending because of the poor outcomes. The pharmacist is in a position, and again, in a targeted manner with data from health insurance claims, we can partner with pharmacists that are well-trained from like the Pharmacy Society through the Wpqc effort, and they can be the ones that see these people 9 to 12 times a year. And actually, with this exchange and good information for the members' willingness to participate, better manage chronic conditions. And what's again important is that pharmacists can be the person that helps get prescriptive authority. Prescriptive changes are absolutely critical. We can only go so far with self-management training. We also need clinical interventions, and the pharmacist is in a key position to do that. So I'm sure it would mature further to perhaps include certain provider systems and value-based contracting, but this model in itself is sufficient to actually get high participation, engagement, activation, and actually get some prescriptive changes consistent with that process. The other things that we're seeing pharmacists can do, We have to work through all this, but we have other programs, for example. The whole idea of population health is to know when somebody has a gap in care or an unmet need and get to them the resource they need at the right time. So, for example, if somebody has an acute back injury and they're coming to the pharmacy with perhaps a script for an opiate or an NSAID preferably, then basically if we have a back pain program and that pharmacist is a partner with us that knows of the existence of that program, they can actually help enroll that person who may not be aware of that program. So I think the pharmacist, again, can be another partner to help align resources, and it all depends upon how the payer wants to kind of explore those opportunities for all the other resources we have where we have lower engagement rates.
All right. Great. That's great. I know pharmacists will be happy to hear that. So we are at the top of the hour. Kari and Alan, I want to thank you again for today's informative session, and I want to thank everyone in our audience for joining us. A quick survey will pop up at the end of the webinar, so we hope you'll give feedback to help us ensure this program continues to meet your needs. I want to wish everyone a great holiday season, and we look forward to seeing you in 2019. So thank you again for attending. Goodbye.